So my name is Teresa Cole. I'm a paediatric immunologist at the Royal Children's in Melbourne, and I'm here today with Dr. Andy McLean-Took, who's a clinical immunologist in Perth. We're here to talk to you about immunoglobulin replacement therapy in primary immunodeficiency. So as we all know, immune deficiencies are a large group of inherited disorders that will impact on either the development or the function of the immune system in a broad range of ways. Many of these we see in pediatrics because they present early with severe infections, but in fact other forms can present later in life, including quite late into adulthood. In fact, some PIDs are more commonly diagnosed in adults rather than children. And unfortunately, it's not uncommon to have a significant delay in making a diagnosis from the onset of symptoms.
So this is a study looking at patients from Victoria, and in 179 patients, what they could show is that across most of the patients with antibody deficiency, with the exception of the patients with XLA who typically presented early in life and had a relatively early diagnosis, there was quite a significant diagnostic delay. And importantly, if you look at the CVID cohort, that delay was up to 9 years, which is actually longer than has been described in some of the European literature. So whilst antibody deficiencies are the most common, they're probably underdiagnosed or only diagnosed after the development of life-threatening infections. As we do all know, the primary immunodeficiencies actually generally are individually not exceptionally common, probably with the exception of an IgA deficiency. But other primary immune deficiencies can be relatively rare, up to over 1 in 100,000 per population. But collectively, these disorders add up to a significant burden of disease across the country. And when do we need to think about primary immune deficiency? We need to think about it when there's an unusually large number of infections. So if you're getting lots of middle ear infections, lots of sinus infections, multiple pneumonias, any infections that are caused by unusual types of organisms, infections that occur in unusual places, and also infections that don't respond typically to antimicrobial therapy. So infections that recur very soon after initial treatment should raise a suspicion for primary immune deficiency. Family members with primary immune deficiency is still the biggest indicator for risk of primary immune deficiency in a patient. And obviously, if there's a family history of immune deficiency or abnormal infections, and particularly if there's unexplained infant deaths, and particularly if there's kinship within the parents, immune deficiency should be considered, as well as children with syndromic features that are known to be associated with primary immune deficiency. So this is a study looking at the initial presenting features for patients diagnosed with primary immune deficiency. And whilst we often think about infection being the major symptom and disorder associated with immune deficiency, it's actually a little bit more complicated than that. And yes, whilst the majority of patients present with infection, so 68% present with infections only, 9% presented with immune dysregulation only, and 9% presented with a combination of both. And the other groups of patients presented with either other features or syndromic features which led to the diagnosis. So whilst primary immune deficiencies may affect multiple components of the immune system, really it's when the normal function of B cells is impaired that we develop problems with antibody production. And antibody production is the most frequent clinically significant primary immune deficiency in Australia, accounting for about 77% of all cases. And the important point is that when we think about primary immune deficiency and recurrent infections, there is a bit of a spectrum of normal infection burden versus abnormal infection burden in patients.
So I'm going to walk you through a case now just to give an example of the sort of patients that we might be asked to consider immune deficiency in. So this is a 4-year-old boy who presented to a clinic with a history of recurrent infections and was identified to have both a low IgA and a low IgM. So with further details from the history, we elucidated that he had multiple episodes of cough and wheeze, which had been treated with both a mixture of antibiotics and prednisolone. He had some mild eczema, but was gaining weight incredibly well. Importantly, there was no family history of immune deficiency, and he had a well sibling. Also importantly, in history taking for children that we might see with recurrent infections, he attended childcare. And you can see here from these results at 2 time points that he had normal IgG, but a borderline low IgA and a borderline low IgM that persisted at the same sort of range. So thinking about him and those results, we decided that this was really recurrent viral respiratory infections in the context of asthma. And with further investigation, identified that there were no significant immune defects. And in this case, no evidence that replacing antibody with immunoglobulin replacement therapy was going to be of benefit for him. Also importantly, we established from his history that there were none of the 10 warning signs. So as Andy alluded to, recurrent or severe and unusual infections should be a flag for potential PID. And the Jeffrey Modell Foundation in America has been very good at publicizing this through the concept of the 10 warning signs. So the things to look for in children, more infections than you'd expect. That can be difficult in children that go to childcare because it's very common. But again, serious infections, deep infections, also for children, failure to thrive, persistent thrush, other signs that there can be an immune deficiency. And pleasingly, in this case, he had none of those features.
So when we think about immunoglobulin replacement, this has actually been going on for some time. So the first human primary immune deficiency was actually X-linked A gamma globulinemia. And this was discovered in the 1950s by Colonel Bruton. This is the chap on the right here. And he had a case of a 8-year-old boy without any family history of recurrent infections. And this 8-year-old boy had had recurrent admissions since the age of 4.5, recurrent infections, the majority of which were due to pneumococcus. And I've just taken these excerpts from the actual original paper because I firstly like the idea of mixing up some penicillin in beeswax and then popping that in the ear. And secondly, I'm pleased that we don't use the turn of phrase that's used in the second statement, suggesting that we should use morphine to keep children quiet. But what the studies on this child importantly did show, and here we've got an electrophoresis, and you can see an albumin band, an alpha, and then the beta, and then the gamma band. And normally this gamma band is where the immunoglobulin is. And you can see that's present on the top one in the normal control, but in the patient who's in the middle, there's 0 gamma band at all. So there's no gamma band to be seen. And when the patient was treated with replacement immunoglobulin, the band became detectable. And actually, this child was treated with subcutaneous gamma globulin, and they could show by measuring total proteins, because this was before being able to measure IgG, that there was an improvement in the total protein, which degraded over time. And this child went from 19 episodes of sepsis over 4 years to no infections at all over the 14 months before this was reported. And so for patients with milder forms of primary antibody deficiency, antibiotic prophylaxis may be considered as the mode of therapy for these. But patients who have severe antibody deficiency or who fail antibody prophylaxis, these are patients who require ongoing immunoglobulin replacement therapy. And even in patients who are on immunoglobulin replacement therapy, some of these patients may also warrant antibiotic prophylaxis as they can experience recurrent breakthrough infections, because whilst we are replacing IgG, we're not correcting IgA or other potential defects that some of these patients may have. But importantly, immunoglobulin is not an easy product to come by, so it's a high cost. And then on the background of increasing demand and consumption, this is becoming a limited supply product. And in Australia, immunoglobulin products, like other blood products, are actually supplied through the National Blood Authority. And so it's the NBA that contracts with the immunoglobulin suppliers to decide which products are available. And then the rules governing the patient eligibility are done through this criteria for clinical use of immunoglobulin, which includes panels of health experts to decide which indications patients are able to access immunoglobulin through the MBA. If there's a patient that is ineligible to access it under these criteria, then they can still access it through a jurisdictional direct order through at a cost to an approved health provider or at a personal cost. So what products are available in Australia? Well, we have what was Intragram P and has become Intragram 10, which is a 10% CSL bearing product. And this is a product which is from non-remunerated Australian donors. It contains a glycine stabilizer, and it does undergo viral donor screening. There are a number of other products which come from remunerated and non-remunerated US and European donors. That includes products like Flebogam, Privigen, Gamunex, and Optigam, and these all contain slightly different stabilizers, which may have some importance for consideration. For example, the maltose in Optigam used to interfere with some of the older diabetes blood sugar monitors. And again, these are virally screened. When it comes to subcutaneous products, IVIg again is sourced from Australian donors, whereas Hizentra, which is also a CSL product like IVIg, is sourced from overseas donors. And then Cuvitru is another one through Takeda, which is again sourced from overseas donors. And again, these have stabilizers which may be relevant for your individual patient. The criteria in Australia are available through the MBA. So there are a number of criteria for primary immune deficiency diseases, which should cover pretty much most of the indications we as immunologists see. It also includes specific antibody deficiency as well. And so these are patients with recurrent infections despite antibiotics and impaired antibody responses. And these are going to be the main indications we would, as immunologists, be prescribing these for primary immune deficiency. When we think about the roots of immunoglobulin, historically, despite that first child having subcutaneous immunoglobulin, actually the gold standard of care became intramuscular, which was limited because it actually was quite painful, thereby limiting the dose. So patients often didn't get a decent trough level after this. And these products contained a high level of mercury, which is also of concern. So in the 1970s, it was identified that intravenous was probably superior to intramuscular. But once they realized the dose could be given at a higher level more easily, it was shown to be clearly superior. And then in the early 1990s, there were a number of studies showing that subcutaneous was equally effective as intravenous for immunoglobulin replacement therapy. And for the primary immune deficiency indications, there's no difference in the criteria between being able to access a product via an intravenous route or to be able to access it via a subcutaneous route. Importantly, there are differences in the pharmacokinetics. So patients who are on subcutaneous immunoglobulin have more of a steady level of IgG due to the more frequent dosing and the slower rate of absorption. Whereas with IVIg, you get kind of peaks, and then this comes down to a trough level. And the aim in both of these is to keep the immunoglobulin level in the blood above the kind of target level when you are due your next infusion. And there are pros and cons to having subcutaneous immunoglobulin or intravenous immunoglobulin. So for IVIg, the cons are it's usually hospital-based. You require IV access, so if you've got poor venous access, that's an issue. It's very clear that the systemic adverse events, the fevers, the chills, the myalgias are more common with IVIg. And some patients in that trough phase, when they're in the dip of their immunoglobulin dosing before their next dose, may begin to experience symptoms with fatigue and mild infections with wear off. The flip side is it's less frequent. If you need to get somebody's levels up quickly, you can do that easily with IVIg. And there's no reliance on the patient to be trained in comparison to subcutaneous immunoglobulin, which is normally administered by the patient. So flipping that around, obviously pros and cons with subcutaneous immunoglobulin. The cons are it is more frequent and local adverse events, so injection site reactions are much more common. Patients will often need access to pumps, particularly if they are administering large volumes, or if they don't tolerate push infusions. They do need to be trained, and unlike IVIg, it's a bit harder to assess true compliance with patients taking their products. The flip side is, of course, this can be home-based, doesn't require any IV access. Because you don't get that drop before your next dose, you don't tend to get wear off. And some patients find significant quality of life benefits. So maybe reduced patient travel or more flexibility when patients are away. But the important point, I think, is that the route of immunoglobulin replacement needs to be considered amongst other things. So actually, what would work for the patient? What resources do you have for pumps and other ancillaries? What are the other medical conditions? So for example, a patient who's got significant thrombocytopenia would not be suitable for a subcutaneous immunoglobulin replacement therapy. Similarly, if they had very severe eczema, that again may make subcutaneous immunoglobulin very difficult. Infusion frequency, some patients just prefer to have once a month and not worry about it too much. And then obviously the presence of subcutaneous tissue in patients who are very malnourished or have other issues, that may sometimes be an issue. But in actuality, in my experience, I think the indication for subcutaneous and IVIg varies and through people's lifetime, and people may well flip from going to subcutaneous to maybe to IVIg whilst they're later on in school. When they go into work, they want to go back onto subcutaneous. With pregnancy, sometimes they find it a bit difficult to administer the subcutaneous immunoglobulin, and often we've had patients elect to go back onto IVIg and then go back onto subcutaneous. So it's not a hard and fast decision. I think patients can change their preference according to what's happening in their life at that moment in time. So I'm just going to talk about a patient, just to consider another factor of immunoglobulin. This is a 52-year-old male who was referred to us having had 5 admissions for pneumonia over 2 years, and these were all radiologically proven. And on one occasion, he'd had a Staph aureus isolated. On another occasion, he'd had a Streptococcus isolated. And he had a kind of history when he was seen of, he's always phlegmy and complained of kind of lots of stuff in his throat, particularly in the morning. He had a background history of mild asthma and hypertension, and when he had a baseline CT chest, he actually had some bilateral lower lobe inflammatory changes, but importantly for somebody this age, no thymoma. And investigations had shown what would it be within our lab, a borderline low IgG. So 5 and then 5.0 on repeat. He had an absent IgA, but this had been historical, so that he'd had an absent IgA on blood tests done some 7 to 8 years ago. And the impression was that this has probably been there for a long time, because he thinks he'd actually been told that had been absent prior to then. His other blood tests looking at his immune function were all unremarkable, and he had a bit of a borderline pneumococcal antibody response following a pneumovax vaccine. So he was, based on his history of recurrent infections, low IgG, borderline vaccine response, was commenced on a trial of intravenous immunoglobulin, which he tolerated well without any issues. But unfortunately, over the next couple of months, despite this, he had two further admissions with a right lobar pneumonia, and decided that it was of no clinical benefit, so stopped this at around the 6-month stage. And at this time, reviewing the history, he complained of this throat pain again and the sensation of postnasal drip. And he went on to have an ENT review with a laryngoscopy, which showed actually he had evidence of laryngopharyngeal reflux. So he underwent lifestyle modification, weight loss, and was commenced on a PPI, and had no further pneumonia episodes after this. So I think this is an important case, just emphasizing that patients should be considered for stopping therapy if there is no benefit, and other potential causes for antibody deficiency be considered. So sometimes people ask, what's the optimal dose of immunoglobulin, and is there a target immunoglobulin trough beyond which we don't get any further benefit against infection? But it obviously, clearly, giving all patients with an antibody deficiency the maximum IgG dose shown to be effective in preventing all or almost all infections would be excessive. And this is just the result of a 2010 meta-analysis which looked at patients with primary antibody deficiency treated with IVIg therapy, and showing that the risk of pneumonia decreased by 27% with each 100 milligrams per deciliter increase in the trough IgG. But actually, on an individual patient level, the more important question isn't what should be the target level for the entire population, but actually what should be the target level for that patient. And this is a concept that's been raised of the biological IgG trough or biological dose, in that the IgG level that is required to keep one patient well may not be the same as the immunoglobulin dose and trough level required to keep another patient well, and this should be individualized for each patient. So here's from a paper talking about two patients, and you can see you've got one patient on the left who really needs to keep their IgG level above 7 to stay well. In contrast, there's another patient who needing to keep their IgG level actually above 9 to stay well. So dosing here needs to be individualized.
So it's very rare in children with genetic disorders of immune deficiency on antibody replacement that they're going to get to a scenario where we would either stop, which is somewhat different for perhaps adults, as Andy's just described. But there is one case and one situation where we may be able to stop immunoglobulin. So I'm going to talk about a case where that's the situation now. So this was the second child born to parents who are known to be carriers of JAK3 variants causing severe combined immune deficiency. We knew that because their first child had presented with lymphopenia and persistent infections resulting in a SCID diagnosis, and that child had undergone a curative stem cell transplant. So this second child we knew about in advance and were prepared for, so had diagnostic tests performed on day 1 of life and was diagnosed with SCID then. So as per the national standards, was commenced on antimicrobial prophylaxis, and as per the immunoglobulin guidelines, was commenced on immunoglobulin replacement. This is the one condition where you don't have to wait for a low trough to get access to immunoglobulin, because we know by definition children with SCID will not produce antibody. This child was admitted for stem cell transplant at 7 weeks of age in good condition. They luckily went on to have a very uneventful transplant course. We transitioned them from subcut immunoglobulin to IVIg through the transplant for practical reasons, and they continued this in the post-transplant period until their central venous access was removed at the 3-month mark. They were then transitioned back to SCIG because they were back home and coming to hospital less frequently, and from a quality of life perspective, that was much better for this small child. And then following on from there, we continue to monitor immunoglobulin with an expectation that hopefully they will get recovery with time. Knowing that this child has been on immunoglobulin replacement essentially for life, looking at IgG levels is very uninformative. We know that IgA, even in healthy children, is very slow to get to normal levels, and after a transplant for SCID is equally incredibly slow to recover. So most of our focus in these children is on their IgM recovery. And as you can see from this graph, the pink line is the IgG level. I think the peaks at the beginning demonstrate very nicely the IVIg dosing through their transplant. And the IgM is the purple level. You can see an early peak, which was associated with a viral infection, but then it dropped off again and then gradually increased towards normal. And you can see that the IgG has trended down slowly towards the end, which is where we'd actually discontinued to try and see whether they could manage without. So what we're looking for in these children is normalization of IgM over time in the absence of a persistent viral infection such as EBV. And that can be a trigger to stopping immunoglobulin replacement after a transplant for SCID. Obviously, it remains very important to monitor for infections, and regular monitoring of IgG levels in that scenario to make sure that they're not dropping too rapidly is important. And then once you've had a washout, it's possible to commence the childhood vaccination schedule and then measure specific antibody responses to demonstrate that they have good functional B cell activity.
So I think in summary, we can say that immunoglobulin replacement therapy, as we all know, is critical for our patients with significant antibody deficiency. The dose needs to be individualized to the patient to keep that patient well and as infection-free as possible. And similarly, the route of administration should be individualized to the patient. And all patients should be regularly reviewed, so make sure that they're on the an appropriate, safe and effective dose, and that any changes in weight or clinical status, the dosage is appropriately reviewed. And not all patients, but most with primary immunodeficiency will require lifelong immunoglobulin therapy, and there may be some situations where a trial of withdrawal of therapy may be considered, particularly if the ongoing need is uncertain.
So that's the end of our talk. I hope you found it informative. Before we finish, we'd just like to highlight some resources for you that are available online that you may find useful. So ASCIA have patient and health professional resources through the links on the website. There are also now an excellent range of NPS MedicineWise resources as well that are designed to help encourage patients to ask the right questions and think about things about what type of immunoglobulin they may want. And then there's also the health professional guidelines for considering immunoglobulin and setting up services through both ASCIA and NPS MedicineWise. And then finally, obviously, the MBA, who have significant volumes of information about access to immunoglobulin here in Australia. Thank you for your time.
Thank you very much.